Okay, there, I feel better. I'm not standing sideways now. Let's see. I assume everybody can hear me. We are going to go ahead and continue our discussion on the bones. Stop and think for a second where I was with this. But we're going to be talking about bones and the, let's see. Well, actually, does anybody have any questions on anything at this point? If not, I'm going to go ahead and jump right to it. Okay, when we stopped the other day, we were looking at, and we had talked about how the bones of the skeleton were initially laid down by as hyaline cartilage, and then we see them calcified over time, over 23 years, or by membranes. The bones of the skull were membranes that were ossified. Now, what happens after we're born? How do we grow there? Because we're seeing we've seen our bones grow gradually while we're in utero. We've seen them start to calcify. We continue this calcification process over the next 23 years. How do we grow in stature? And that's the term postnatal bone growth. The bones will grow lengthwise. We will achieve our adult stature through growth at the epiphyseal plate. Remember, the growth plate is an area of hyaline cartilage between it's between the epiphysis, each epiphysis, and the shaft of the long bone. The epiphysis and the diaphysis. The diaphysis is a shaft, so there's a proximal epiphysis at the top of the bone and a distal epiphysis at the bottom of the bone, and the bones will grow outward from those two growth plates. Those growth plates shut down by the time we hit age 23. Most of our overall growth has occurred during adolescence, and we don't see much more growth. And eventually those growth plates will close completely and leave a epiphyseal line, the scar, if you will, of the growth plate. So we've achieved our adult stature, late adolescence, somewhere in that time frame, and then we will go shut down the growth plate. The only bones that will continue to grow normally after the shutdown of the epiphyseal plates are the facial bones. The nasal bone may grow, the mandible may grow, the frontal bone may grow slowly over time. This is a normal occurrence over time, a very slow growth process that may or may not be happening with individuals. So what we do see happening is that we remodel our bones. The epiphyseal, with growth, we saw a lengthwise increase in the size of the bone. Growth hormone is stimulating the epiphyseal plates to grow, and we're generating more cartilage, and the cartilage becomes converted to bone at the ends of the long bone, and so we grow. But after we have reached our adult stature, the epiphyseal plate shuts down, and all we do now is grow side to side. We call it appositional growth. Our bones will enlarge or shrink based on the demands that we place on them. We're no longer trying to reach our adult stature. We've reached that. Now we're going to sculpt, if you will, our bones so that they meet the demands of our body. Are we a runner? Do you like to run? Do you like to swim? Do you like to lift weights? Do you like to hike? Do you like to exercise? Your bones are going to respond to that. Do you like to do nothing? Your bones are going to respond to that. It's whatever your body is doing is how the bones are going to respond and shape their structure due to caused by the various stresses that you are placing on the various bone cells. So the epiphyseal, to recap, the epiphyseal plate gives us long bone growth. You know, we have one at each end of the bone. In there's a distal epiphyses and a proximal epiphyses, and that's where our bone growth is going to take place. And right there, for example, there's a femur. There's where the epiphyses are, here and here. Once we reach maturity, all we have left is a line that shows where the growth was. The epiphyseal line is simply the remnant of the epiphyseal plate. The plate is where the long growth took place. The appositional growth is going to take place throughout the length of the long bone. It's going to become thicker or thinner based on the demands you place on it. So what controls all this? Well, growth hormone obviously is number one hormone. It stimulates the epiphyseal plates to become active, to stay active throughout childhood and into adolescence. The thyroid hormone has to come in and increase metabolic activity, so we have the energy for growth. The presence of testosterone or estrogen at the onset of puberty stimulates the rapid growth spurts we see during that time frame when we're rapidly reaching our adult stature. And the testosterone and the estrogen stimulate so rapidly that we get our growth, but it stimulates the growth plates to the point where they shut down. And when they shut down, then our adult stature has been achieved. And the hormones, estrogen and testosterone, they're very, very similar in structure. This is estrogen on the left. You know, it is based off of a steroid. It's a 4-ringed structure, very similar in shape to cholesterol. And you'll notice that testosterone is also very similar in shape to cholesterol and very similar in structure to estrogen. What happens here at puberty, the estrogens in the female will cause the osteoblasts to produce bone faster than the epiphyseal plates can divide. So our normal bone growth causes the cartilage to grow and divide and grow and divide and grow and divide. However, when we have high levels of sex hormones in the female, the estrogen will stimulate the osteoblasts to undergo mitosis rapidly, much faster than they would normally with just the regular going through the hyaline cartilage at the epiphyseal plate. However, this growth spurt also dooms the bone to grow to a certain point and then stop. The bone will achieve its ultimate growth, its ultimate stature, because it will grow rapidly and reach that ultimate stature, but it will be growing so rapidly that the growth plate will shut down, and then you have achieved your adult stature. Now, estrogens trigger the growth plate to shut down early in females sooner than they do, or earlier than they do in males. Now, in males, it isn't testosterone that's driving this. It's another hormone called the androgens. Now, the androgens are sex hormones, essentially testosterone, produced in the adrenal glands in both males and females. The androgens in females are converted to estrogen. In males, they essentially mimic testosterone. The androgens tend to, in males, tend to be released a little later in puberty than in females. So males tend to have their growth spurt a little later than females do. and it lasts longer because estrogen stimulates the growth plate in the female bone to grow quickly and then shut down. You know, the growth spurt occurs so rapidly in the female that it actually ends up closing the epiphyseal plate down, and you stop growing. In the male, the androgen doesn't have that closure. The male will continue to stay. The androgens cause the growth plate to continue to be active, to have continued osteoblast activity without closing down the growth plate immediately. It grows slow. It shuts it down slower. So your male adolescent will tend to have an active growth plate and osteoblast activity longer than the adolescent female will. So your adolescent male tends to have an average body stature higher, larger than the female. So we, both of these, so the growth activity at puberty is driven by the presence of estrogen and these androgens. Okay. So what else do you need for growth to occur? Insulin. Insulin stimulates bone growth. It's not enough. It has to go after blood sugar. It has to help with bone growth too. Glucocorticoids, hormones from the adrenal cortex, will work by inhibiting osteoclast activity. So you're going to have more growth taking place. Glucocorticoids inhibit the bone cells that break down bone. So we see bone growth continuing here if we're releasing more glucocorticoids, like cortisol, for example. Now, the two hormones that affect calcium levels, because you can't have bone growth without calcium. You got to have calcium to be deposited. The calcium salts have to be deposited in the matrix as the osteoblast is laying down the matrix. So there are two hormones here that regulate blood calcium levels. That's where our calcium comes from. It comes from our blood. So we have these two hormones that are going to regulate that. One is called parathyroid hormone, and the other is calcitonin. They are antagonists. They work against each other. Parathyroid hormone stimulates bone breakdown to release calcium. And we use this all the time when we're remodeling bone. And calcitonin stimulates bone buildup and uptake of excess calcium. So these two hormones can regulate the breakdown and the buildup of our bone. So parathyroid hormone and calcitonin. So how much do we remodel daily or weekly? Well, we actually, about 5% of our bone mass is recycled every week. We replace our entire skeleton of spongy bone about every 3 years, and our compact bone is replaced every 10 years. So we have a completely new skeleton every 10 years. And this remodeling is based on both deposition of new bone and breakdown of old bone. We use the osteoblast to lay down new bone, and we use the osteoclasts to tear down the bone. The osteoclasts packed full of those lysosomes that are going to be dissolving away bone. So, and we do it on both sides of our bone. We do it on the periosteum side of the surface of the bone, and we do it on the endosteum. And when it's not a random action in different locations. It's very organized. The osteoblasts and the osteoclasts, when we're remodeling bone, are side by side. We're dissolving bone and building it back up at the exact same time. So, remodeling is controlled by two things. It's controlled by the presence of hormones. We use a negative feedback loop to make to maintain our blood calcium levels. If we need more calcium for bone, if we're remodeling, we will dissolve old bone that we want to replace, so we can lay down new bone. If we have excess calcium, we can lay down new bone in here. So we control the hormonal controls on remodeling involve the use of parathyroid hormone and calcitonin. Now, something else we have to have to maintain our blood calcium levels is vitamin D. Vitamin D has to be present for us to absorb calcium in our small intestine. So the vitamin D we get in our milk, the vitamin D we get in our skin from ultraviolet radiation, the vitamin D we get in vitamins, we have to have vitamin D present or we can't absorb calcium in our small intestine from our diet. You have to have vitamin D. Like milk has vitamin D in it, and milk has calcium in it. So we can use the vitamin D in milk helps us to absorb the calcium we need for our bones. Now that's the hormonal aspect of remodeling. What about mechanical stress? What if you've decided that you want to be an Olympic weightlifter and you are exercising and you're lifting weights every day? That's putting stress on your bones. How do your bones respond to that stress? That's mechanical stress. Okay, first of all, let me go over this again about calcitonin and parathyroid hormone. I got a little carried away with myself. Calcitonin, it's produced by what are known as the parafollicular cells of the thyroid gland. This is getting into a lot of endocrine science here. We're going to cover all this in AP2, whether you take it with me in May term or take it with me in the fall. We're going to cover the first chapter, first unit in AP2 is all about hormones. So calcitonin produced by what are called the parafollicular cells in the thyroid gland. If blood calcium gets too high, the parafollicular cells produce calcitonin, and the excess calcium is deposited in bone. If blood calcium levels get too high, excess calcium can be dumped into new bone. Now, this is not a major player in regulating calcium levels in our bodies. We usually don't have excessive levels of calcium. But if we did, or if we do, then calcitonin comes into play and allows us to lay down more bone. The hormone that does most of the regulating is parathyroid hormone. It's produced by the parathyroid glands. These are little tiny glands on the backside of the thyroid, and they detect low blood calcium levels. If blood calcium levels drop below a preset level, then the parathyroid hormone will stimulate our osteoclasts, start breaking down bone. That will release more calcium into our blood and raise our calcium levels. And we, again, it's classic negative feedback. When the calcium levels get back up to where they're supposed to be, we stop releasing parathyroid hormone. Negative feedback. The stimulus is low calcium. We bring the calcium back up. We reverse the stimulus. So parathyroid hormone is the key hormone here, because we're always going to have low calcium levels. So we always want to bring the calcium levels back up, because we're always making bone. We're always tearing bone down. We're always using calcium for other things. And so we're always going to be in a state of perpetually lower than normal calcium. So we're always dissolving bone to bring it back up and then replacing that calcium somewhere else. So, okay, this is the feedback loop for calcitonin. It's very straightforward. If blood calcium levels go up, on the left-hand side there you see blood calcium levels go up. That stimulates the release of calcitonin from the parafollicular cells of the thyroid gland. That inhibits osteoclast activity. We don't break down bone. If our blood calcium's high, elevated, We're not going to be breaking down any more bone, and we're going to be building more bone up. So we inhibit osteoclast activity, the bone breakers, and we stimulate osteoblasts, the bone builders. Parathyroid hormone, on the other hand, is controlled by the is going to be producing parathyroid hormone in response to low blood calcium levels. This is the backside of the thyroid gland. These are the parathyroid glands here. There are 4 of them on the posterior surface of the thyroid gland. They're about this, literally about the size and shape of a raisin. There are 4 of them, and they will release parathyroid hormone if blood calcium levels drop. So what's going to happen is they will inhibit the osteoblasts. The bone builders will be shut down. The cells that lay down the matrix, they will be shut down. Osteoclasts will be stimulated. They will start dissolving bone right away. That's the first thing that happens. The second thing that happens is that we start absorbing more calcium in the small intestine. That's where vitamin D comes in. We have to have vitamin D to be able to absorb calcium. So the first thing we do is we start dissolving bone with the osteoclasts. Then we start absorbing more calcium in the small intestine, thanks to vitamin D. And the third thing we do is we stop excreting calcium in the kidneys. We stop peeing away the calcium that's in our plasma, and we start retaining that. So there's 3 different ways to keep the calcium levels up in our blood supply. And here's the flow chart. And at first glance, it looks like a busy flow chart, but it's really not that bad. We start at the top here. We have blood calcium levels drop. Okay. We release parathyroid hormone from the parathyroid gland. 3 pathways. We stimulate osteoblasts to stop working, or rather we inhibit osteoblasts. We stimulate osteoclasts to start breaking down bone, and that releases more calcium. So we have our blood calcium levels go up. We break down bone, release calcium, and now we have more calcium in the blood. That's the first pathway. The second pathway is we increase the calcitriol. Calcitriol activates vitamin D. The liver produces calcitriol and it activates vitamin D, and that means that we can absorb it easier in the small intestine. So we get more calcium. We activate vitamin D. It means we can absorb calcium in the small intestine. And third thing is it tells the kidneys to stop peeing away calcium. Instead, we retain calcium. So all 3 of these combine to give us a higher blood calcium level than we had before. This is the major hormone that controls blood calcium levels. Calcitonin just sort of watches, because we very rarely have high levels of calcium in our blood. Okay. Problems with calcium, though. Too much of a good thing is bad. So is too little. If our calcium levels are low, excessively low, we become hyperexcitable. Our nervous system doesn't like that. We become agitated and extremely sensitive to stimulus. If we have too much calcium, too much of a good thing is also bad. We become non-responsive to stimulus. Hypercalcemia, we become much less responsive. We become hypoexcitable, so we don't respond to a stimulus. Further, excessive levels of calcium in the diet can lead to the formation of kidney stones. We call them renal calculi, based on calcium. A person who maintains a steady diet of foods that are very high in calcium run the risk of developing a kidney stone, because that calcium accumulates in the kidneys, and it causes You know, it's a salt. It crystallizes inside the kidneys if we have excessive levels of it there, more than the kidney can, you know, retain or pee away. And so we end up with these very large and painful sharp-edged stones forming in the kidneys. So, okay. What else hormone-wise besides calcitonin and parathyroid hormone do we have? Well, leptin. Leptin may inhibit osteoblasts. The adipose tissue releases this. Serotonin, our mood stabilizer, may interfere with osteoblast. So both of these, leptin and serotonin, are going to sort of get in the way of bone building for whatever reason. Now we get to stresses. What about stress? Bones get stressed when we apply weight to them. When muscles pull on bones, or when we're using the bones to lift up, you know, become load bearing, you know, bones are stressed. And there is a law. Now, I don't ask you to learn very many laws in AP1. In fact, I think this is the only law that I asked you to learn in AP1, and only a handful of laws in AP2. These physiological laws. This one is called Wolff's Law. Wolff's Law says that bones will grow or remodel in response to the demands placed on them. Meaning, if you are a weightlifter and you're lifting greater and greater loads as a weightlifter, or you're exercising vigorously, maybe you like to row, maybe you like to bicycle. The stresses that you're placing on your bones from the weight applied to them, or from by being the muscles pulling them, causes the bones, in this case, to enlarge. The muscles are getting stronger. The muscles are pulling, are affecting, have a more powerful influence on the bone. The bone responds by getting bigger. The bone enlarges in response to the stress you're applying to it. Or if you're not doing any of that, your bone reduces its size. The bone shrinks in size. You have the bone has less mass than it did before. So you're either going to see the bone, you know, Wolff's Law says that bones grow or remodel in response to the demands placed on them. If the demands go up, the bone gets thicker. If the demands go down, the bone gets thinner. You know, an astronaut in the space station's bones are going to be much thinner or much lighter than a corresponding individual on Earth, because there's no gravity, and you know, no matter how much you exercise in the space station, you're not going to be able to mimic the effect that gravity is having on your body. So our bones will change their shape based on what we're doing to them. You know, if we're applying a great deal of mechanical stress to the bone will get bigger. If we take away a lot of mechanical stress, the bones will get lighter and thinner. So our bones will, the diaphysis, the shaft, will become very thick where the stresses are the greatest. And so we have our bones get very large. Now there is a limit to how big our bone will get. You know, once our bone can, you know, there's a limit to how strong the weight is, how strong the pull is on the bone. There's a limit to how much the muscles can do. There's a limit to how much the bone can process. So the bone will reach that size and not grow anymore. It may get thicker a little bit or refine its shape, but it's not going to get much bigger. Wolff's Law also, in addition to responding to the stresses applied to it, Wolff's Law also explains our right hand or left hand dominance. If you are right-handed, the bones of the upper arm are going to be larger, because the dominant side is going to be doing more work than the non-dominant side. So the we see this, if an individual is ambidextrous, then both arms are going to be equally thick. But if you're right dominant or left dominant, the dominant side is going to have larger bones because you do more work with that particular limb. The trabeculae in the spongy bone in the dominant arm, for example, are going to line up where the stresses are going to be the greatest, because trabeculae are going to spread shock out. So, and here's something else to consider. The attachments of the muscles to the bones are going to become very large and very strong, because this is where if the reason that the bones get larger is because the muscles are getting larger. The stresses applied to the bones are based on the stresses applied to the muscles. And so the muscles have to have a greater point of attachment, a more powerful point of attachment. So the bones will thicken dramatically at the area where the muscles attach as the muscles enlarge. So it's something we would see, in weightlifters and gymnasts and anybody that's going to apply a great deal of stress to their bones, which is being passed to coming from the muscles themselves. If you don't apply stress, then the bones shrink. The bones become lighter. They become weaker. They lose a lot of their features there where the muscles attach. So Wolff's Law explains it both ways. The bones get bigger when the stresses are greater. They get smaller and lighter when the stresses are least. So, and okay, now let's move on here. Okay, again, bone remodeling. I can't emphasize this enough. The bones remodel based on the stresses that are applied to it, but they also remodel on a weekly, monthly, and yearly cycle in here. Our bone will get larger at the point of attachment of muscles if we're placing a great deal of stress there, or they will become lighter and thinner. Lighter and thinner instead of thicker and larger. So, again, it is a significant problem in astronauts that are in space. When they're, because if they're in space for a great length of time, like a year, their bones are going to become very lightweight, very thin. They cannot deal with the stresses that are going to be reimposed by gravity immediately. So because they can't support the body. Now they'll recover very quickly, but most astronauts that when they come back from space for a year are usually assisted out of the landing craft because they can't really stand upright very well. Okay, now let's talk about fractures, injuries. Many of us have broken bones. Many of us have had fractures. A fracture is a break. We have sort of a twin peak approach here on fractures. When we're young, we break our bones. We have fractures from trauma. Young and adolescent and young adulthood. It's like, hey, hold my beer, watch this type of approach when we're in that age. But when we're younger, we all do things that get bones broken. Most of the bones broken in adolescence, young adulthood, and childhood result from trauma. Fractures in old age come from the bones thinning out. They still come from accidents, but a lot of those breaks occur because the bones are much weaker. Something that a person, an average adult, may trip and fall down and bruise their arm or bruise their leg, but not fracture their bone, where an elderly person might fall and fracture their leg, their hip, their arm, their wrist, whatever. So bones do pretty well dealing with stresses and dealing with sudden blows and trauma, but they do break. if there is some sort of extreme loading or stress, a person falls down, a person is hit by an object, something breaks loose and slams into their leg or their arm, or they fall off of a ladder. Sudden, unexpected trauma can cause a bone to break. Now, how do we heal? How do we cause that bone to heal? We don't do anything. The bone will heal on its own. Now, what affects the bone is whether or not the bone tissues survive the trauma, and particularly the outer covering of the bone, the periosteum, and the inner covering of the bone, the endosteum, and whether or not the blood supply has been impaired in any way. But bones will heal up on their own. Most fractures take about 6 weeks to heal, whether we do anything to it or not. So fractures can be looked at. I almost said broken down. Fractures can be classified by the type of break that we get. What is first of all, where's the bone end after the fracture? Is it non-displaced? I mean, is it still lined up? You have a fracture in your ulna, and the ulna is still intact. You can see the break there, but the bone hasn't moved. The ends of the bone are in their normal spot. A displaced fracture, the ends are out of alignment. So you're not lined up properly. Is the break all the way through? Is it a complete break, or is it an incomplete break? Is it only partially fractured? Is the skin penetrated? Is it an open fracture, a compound fracture where the bone's sticking through, or is it a simple fracture, a closed fracture where the skin isn't penetrated? You may have a closed fracture that is a complete fracture that is displaced. You can have a closed fracture that is incomplete and non-displaced. You have all permutations here that can take place. So different types of fractures. There is open and displaced. We have the humerus broken in half, and part of the humerus is sticking through the skin. Here we have what's known as a green stick fracture. Very common in children because their bones are much more flexible than an adult. So we call it green stick. It's like when you take a branch on a tree and you want to see if it's alive or not, and you break it, you try to break it and it doesn't snap all the way through. Oops, it was still green. So that's why they call it a green stick fracture, because young bones don't break all the way through. Usually they break only on one side or the other. A comminuted fracture is when you shatter the bone and have lots of bone fragments around the side of the fracture. A linear fracture runs the length of the bone. In this case, it's vertical. You get a lot of these types of fractures if you break your fingertip, the distal phalange at the end of your finger will often break in a linear manner. And those kind of fractures are the easiest to treat because you just end up taping your fingers together. The transverse fracture, non-displaced, yes, it's broken, but it's not out of alignment. There's no oblique fracture that's non-displaced. It's at an angle, but it's still not out of alignment. Spiral fracture. This is a very common sports injury. This is your athlete puts their foot down and tries to turn their leg, only their foot sticks in the ground for whatever reason. Maybe it's muddy, maybe it's not. Maybe it's just a fluke that their foot doesn't turn with them and the bone snaps. A Cole's fracture, you can see the fracture is occurring right up in here at the end of it looks like the ulna there. And over here we have what's known as a pot fracture right at the tendon. The tendon breaks here, but then we have a corresponding fracture over here on the fibula. So now, is this the worst fracture ever? this is a gymnast at the Olympics last year, whenever we had I think it was last year. Anyway, floor routine, she comes up and she goes to hit the mat to start her floor routine, and she landed awkward, and you'll notice that she fractures her legs at the knees. The tibias both break. Notice how her legs are bending backwards. Not supposed to do that. Notice how her tibias over here are now below the level of the knee, because they apparently had a clean fracture all the way across here. This is an accident. This is trauma. We don't expect, trauma occurs when we don't expect it. We've all had, if you've ever had a fracture, we certainly didn't expect to break something. And in this case, just by, as they say, a freak accident, she apparently she hit the floor wrong and broke her tibias. Yes, exactly. Ouch. It's still painful to look at this. So now, probably the worst fracture ESPN ever covered was a football game back in I want to say in the late 80s. It was a Monday night football game, and it was Washington against New York. And you'll notice that the Washington quarterback here, you can still see the ball in place right there, is being tackled. But notice the angles that his leg makes. His femur snapped in here, as well as his tibia. So, and they said that the crack of the bone of the tibia breaking was audible on TV. So, needless to say that he certainly didn't walk this off, but it was this, your leg's not supposed to bend in the angle that you see there. No. Stress fractures, neck of the femur. Neck of the femur is the classic spot for a stress fracture because this is where some undue stress is applied here. The neck of the femur is where osteoporosis tends to dissolve away the spongy tissue that is allowing you to turn your leg in multiple directions, to move all around in different directions and to deal with stresses from all different angles. Well, what happened here is the neck of the femur is shattered across there. This is when we say that the person broke her hip or her hip, his hip or her hip, but it's not the hip per se, it's the neck of the femur. Something snapped that, and it could be something as simple as tripping and falling on a rug, sneezing violently or vigorously, coughing hard, stepping off of the sidewalk, getting out of a car, rolling over in bed, anything. It creates a sudden undue stress on a weakened bone, because the bone is very weak in here for this to occur. Now, in this it looks like this is an MRI, and so you can't see inside the bone here in this particular image, but it's very likely an X-ray would show a lot of dark area in here, because remember, in osteoporosis, the spongy bone is gone, the calcium is gone, so you don't see any bone underneath the compact bone at the surface. So how do you treat a fracture? Well, the term is reduction, where you realign the ends of the bone. You line them up again so they'll grow back together. A closed reduction is the simplest. You simply manipulate the ends of the bones so they line up. You can feel them grating against each other, and you can tell when they're lined up properly, and then it will grow together on its own. Open reduction requires surgery to wire the ends of the bone together, so the new bone can grow around the pins, the surgical pins, the wires in place here. Typically, when you have reduction, you have to immobilize the bone so that It doesn't move out of alignment. You can apply a cast, whether it's a walking cast or there's the lightweight casts. These are made out of fiberglass that work very well. Sometimes your patient is placed in traction. It's pretty extreme to hold the bone, the long ends of the bone together so they can grow. The healing process usually takes about 6 weeks for the bone ends to grow back together again. But it depends on a lot of things: the type of the injury, the age of the patient, what bone got broken. If you break the end of your finger, you're going to tape it together for a couple of weeks and it's going to heal. It's going to grow back together again to the point you're not even aware that you broke it. It just happens. There's for a lot of small bones, there's not a lot you can do. In case in point, right before Thanksgiving, I dropped a 25-pound turkey, frozen turkey, on my toe, on my little toe on my right leg, accidentally. I was pulling it out of the freezer. The wrapping around the frozen turkey tore, and bird dropped 3 feet on my toe, and there was nothing I can do about it. I just had to let it heal up. There was a lot of swelling, a lot of redness, a lot of pain, and then it got better. And after about a month and a half, I didn't even think of it. But for the first 2 weeks or so, it was pretty painful, but it's going to heal on its own. There's nothing you can do to repair it. It will heal on its own. So now this is fracture reduction. This is an open reduction. This is surgery involving a fractured tibia. Breaking a tibia takes a lot of work when you think about it. Tibia is probably the second strongest bone in the body, right after the femur. But here you can see we have a plate and at least 3 screws holding the fractured ends together, and 4 large pins. Now this structure out here that holds the pins is outside of the leg, and so these pins actually penetrate through the skin into the bone. They will eventually be removed after the bone grows back together again. So this is an open fracture that has been surgically repaired. You also notice that it looks like the fibula took a hit too, because there's a fracture of the fibula, and that hasn't even been addressed yet in this picture. So now, this is what it looks like from outside. This is open reduction. You can just see the bone in there, and here we see the pins penetrating through the skin, and this bar holding the pins in place, and eventually they will come out. And it doesn't hurt very much when these pins come out. Here we see the ulna. Here we see a displaced fracture of the ulna and the radius. You can see that this involved a series of metal plates and screws. In here, the bone will grow over. You can see these are staples. As those little metal structures are there, you can see where the staples are holding the skin together. And it looked like it must have worked fairly well, because the cast is off now on the arm. Or maybe they just took it off to take out the staples, I don't know. But you can see it was a pretty vigorous fracture here, if you will. So, yeah. Hip replacements, I've shown you this in lab, but again, we can have various types of hip replacements when a hip is broken. Nearly always the hip replacement involves putting an insert in the acetabulum and a new head on the femur, and depending on the weakness of the femur, you have 3 different choices in the type of shaft you have for the artificial hip. Do you go to can you put it down, put it right into the neck of the femur? Do you have to extend further in the neck, or do you take the head and neck off and run it all the way down the medullary shaft? and you have various options here and that. And these work very, very well on your patients. They recover their mobility. Often this occurs after a hip fracture, because the old therapy for a hip fracture was to surgically reduce the fracture, perhaps take shavings of bone from other parts of the body and pack it in around the neck of the femur, immobilize it with a body cast, and apply traction and stick grandma in a hospital bed, for 6 months. Well, grandma's going to be dead in about 2 weeks anyway, because you've immobilized grandma and she's on her back, and she will eventually aspirate fluid into her lungs at some point. She can't help it, which likely will turn into pneumonia, which will kill her. So the hip fracture, the old treatment of casting, putting a body cast on the individual or a half body cast with lots of traction and immobilization, probably killed a lot more patients than it helped. Once the idea of putting in an artificial hip came in, the mortality rate from hip fractures dropped drastically. Plus, now they're getting their mobility back. Yeah. Okay. Sometimes hip replacements aren't always the best. No, actually, they are pretty good. And many people opt for hip replacements before they have an injury. Now, I've shown you this in lab about why knee replacements are so effective, because we take off the damaged bone and the damaged cartilage menisci in here, and we put an artificial covering over the condyles of the femur and the condyles of the tibia, and an artificial meniscus. And since we haven't removed the medial and lateral collateral ligaments, we are still attached to the femur and the tibia. We also didn't take out the patellar ligament, so we're attached to the femur and the tibia in the front too. So we still have all of our connections, and the joint works so much better. So now our bodies, though, will also heal up the injury. Our bodies will do, whether we do anything or not. And an individual that has a fracture that was non-displaced, as long as they immobilize that arm or leg or tibia or femur or bones of the wrist, that bone's going to heal up. It may not heal properly. It may not heal the way you want it if you didn't do it, if you didn't reduce the fracture properly, but the bone will still heal. Now, the first thing that happens at an injury is a big blood clot. It's called a hematoma, because when you fracture a bone, you're going to tear blood vessels. Remember, bone is living tissue. So you've torn these blood vessels, and you have a lot of bleeding into the site of the injury. And we have swelling. We have a lot of pain and heat and discomfort. And there's bleeding into the injury, and eventually that stops. We form a clot, and bleeding has stopped, but now we have this break in the bone. So the first thing we see is pain, swelling, heat, a lot of discomfort in here going on. Now, after we absorb all of the excess blood that has leaked out into the tissues, then we're going to start laying down what's called a callus around the end of the two broken bones. At the site of the fracture, we're going to form a callus. A callus is a thick band of connective tissue made out of cartilage and fibrous tissue. Fibrocartilage and hyaline cartilage and fibers, reticular fibers, for example, elastic fibers, collagen fibers, are going to be woven around here in a band. And that's called the Fibrocartilage Callus. And that's going to sort of stabilize the area. It's almost like a cast, a very weak cast to hold things together. It allows blood vessels to grow from one side of the break to the other, to replace the damaged ones, or to reconnect. So we grow new blood vessels. We do this all the time. We're always growing new blood vessels. The third step is we convert that cartilaginous callus into a bony callus. We start growing spongy bone and start laying down compact bone, and the bone fills in the side of the fracture. And we have new osteocytes in there, and we're reshaping the bone, and eventually the callus goes away and the fracture is healed. And that, from start to finish, from 1 to 4, when we get to the remodeling stage, we're probably, remodeling is like the 7th and 8th week after the fracture. The fracture is essentially healed after about 6 weeks. We didn't do anything. If we did nothing to the fracture, this is still going to happen. If we reduce the fracture, then it'll heal properly. If we don't reduce the fracture, it'll still heal. And it may heal properly anyway, depending on whether or not you needed to reduce it. If there's no displacement of the bone, like with my little toe, for example, the bone's not displaced, there's nothing I can do. It'll make it more better, if you will. It's lined up, it's still lined up, and it's going to heal on its own, because this is the process we go through when we have a fracture. So the hematoma forms. This is where the greatest amount of pain is coming from this hematoma, because you're swelling. And when you swell up, you press against pain receptors. That's where the swelling causes a great deal of pain. It's going to be red. It's going to and inflamed, because you have increased blood flow at that region. Not only do you have a clot forming at the hematoma, but you're bringing in more blood to bring in more red cells with oxygen. You're bringing in glucose. You're bringing in white cells to fight infection. So you've increased the blood flow into the area of the injury. So you get inflammation, you get swelling, and you get pain. And of course, as I said, you lay down your callus. Your first callus is fibrocartilage. Your second callus is going to be the bony callus. From the fibrocartilage callus to the bony callus is about a week. And then this will stay in place for about 8 weeks after that. But by the end of, by about 6 weeks out from the injury, you're going to, be pretty much back to normal in here. And then you're going to have some remodeling to do. But so 2 months altogether after the injury, your bone is as good as new. It's not weaker than it was before because of the site of the injury. It is essentially healed. And then bone remodeling, and it will look like the same bone. It will respond to the same stresses. It will do the same things it did before. So what do we have to eat and drink? What do we tell our patients we have to eat and drink to maintain good bone health and bone growth? Well, we have to have calcium and we have to have phosphates. Calcium and phosphorus are required for strong bones. Now, to get calcium and phosphorus into our blood, it's like everything else we eat and drink. Everything else we eat and drink, everything that we eat and drink is absorbed in the small intestine and goes into our blood supply after being cleaned up in the liver. So everything ends up in our blood. Everything that we absorb. Calcium and phosphorus don't get absorbed in the small intestine unless vitamin D is present. Vitamin D, also known as cholecalciferol. Vitamin D has to be present for us to absorb calcium and phosphorus. So we get vitamin D in our diet. We get vitamin D in our skin. Exposure to ultraviolet radiation in our skin stimulates the production of vitamin D. All we have to do is activate the vitamin D. Once vitamin D is activated, then we can absorb calcium and phosphorus. But we have to have vitamin D. Milk is a great source of vitamin D. You know, milk, vitamin D is added to whole milk. Whole milk doesn't contain vitamin D. It's added to it. Now, whole milk is a great source of calcium. So whenever whoever decided to add vitamin D to whole milk, it was a brilliant move because you get calcium and you get vitamin D. And now it's practically unheard of to think of milk without vitamin D added to it. So fresh cow's milk, though, I will tell you, fresh cow's milk, high in calcium, 0 vitamin D. Other vitamins we need vitamin C, A, K, and B12, but the two big ones, the big one is vitamin D. So we get vitamin D from vitamins. We get it from sunlight. We manufacture ultraviolet radiation stimulates the production of vitamin D. Now, vitamin D is converted by the liver into its active form. It's also converted into its active form in the kidneys. The active form of vitamin D, because cholecalciferol is converted to calcitriol. That is the active form of vitamin D. When we have them activated, when vitamin D is activated, then we can absorb calcium and phosphorus in the small intestine. Okay, let's talk about problems with our bones. Now, this is some of the more interesting aspects of our bones, or the things that go wrong. There's all sorts of things that can happen to our bone. There are 3 categories of bone diseases. The first one is called Osteomalacia and Rickets. Osteomalacia is essentially soft bones in adults. In children, we call it rickets. The characteristic sign of rickets or osteomalacia is the legs bow out or they fracture suddenly. On X-ray, they look like they have been eaten by a moth. Okay, that's number 1 is osteomalacia, weak bones. Osteoporosis is the second bone disease we pay attention to. Osteoporosis is a condition where we dissolve away most of our spongy bone. Osteopenia is the precursor to osteoporosis, meaning we see some bone dissolving, but it's not the full-blown effect that osteoporosis gives us. And the third category of third bone disease is called Paget's disease, where we have uncontrolled bone growth in different regions of the body. We think it's viral, but we're not certain. Now, those are the 3 big bone diseases: osteomalacia, osteoporosis, and Paget's disease. Now, other things that can happen is a condition known as gigantism. Gigantism occurs when growth hormone from the pituitary gland is secreted in high levels starting in childhood. It causes excessive overall growth. Your patient with gigantism may frequently grow to exceed 8 feet in height. Hypersecretion of growth hormone causes gigantism. Now, there's a second variation on this. It's called acromegaly. Acromegaly is hypersecretion of the growth hormone, but it only occurs in adults. A person with acromegaly would start secreting high levels of growth hormone after they've reached their adult stature, after the epiphyseal plates have closed. You have your individual, they're 5.5 feet tall, and all of a sudden they start secreting large amounts of growth hormone. The only bones that can be affected are going to be the facial bones and the bones of the hands and bones of the feet. So this is acromegaly. Also, excessive growth hormone, but only after the growth plates have shut down. The third condition that can occur is pituitary dwarfism. Pituitary dwarfism is an absence of growth hormone or a reduced amount of growth hormone during childhood and puberty. Your individual doesn't get the growth spurt. They don't have typically the average normal size of their long bones, and so their body stature does not get above 4 feet. This is a pituitary dwarf. Everything is proportional in size. Now, so pituitary dwarfism is the third condition. So osteomalacia and rickets, poor mineralization here. You know, why? We don't know. You know, I can tell you why, at least in children, but we don't know, what's the cause of it? Is it dietary? Is it an absence of vitamin D? Whatever. Osteomalacia, the bones are, have low level, or say poorly mineralized. I was trying to say a good way about calcium. Calcium levels are low. Okay. The calcium salts are not adequate to cause the matrix to harden properly. The bones are soft. The bones are weak. It hurts to put weight on them, to stand on them. The legs will, for example, will bow outward. A person with osteomalacia frequently might experience a fracture of their leg while standing in line for something. In children, the legs are going to be bowed outward because they can't support the weight of the torso. What happens with osteomalacia and with rickets is the bone ends, the epiphyses become very large. You know, they're growing, but they're not strong. It's, again, our bodies, you know, if some is good, more is better, but they're not strong ends. And so the legs bow out because they're very weak. Now, rickets can be treated very easily with vitamin D and calcium. Usually children that have rickets have a dietary component here at the problem. They haven't had enough vitamin D. They haven't had enough calcium in their diet. Maybe they're getting all the sunlight they want, but they're not getting the calcium. So generally don't see a lot of rickets in the US like we did 100 years ago. Osteomalacia, yes, because we don't know why the calcium isn't being deposited in the matrix. Osteoporosis. It is not one disease, it's a variety of diseases where we break down, essentially we're breaking down our bone faster than we're building it up. We are dissolving our bone using our osteoclasts to dissolve the bone quicker than the osteoblasts are building the bone. Look at the top picture there, A, there's a normal trabeculate. It tends to go after spongy bone. It goes after the spongy bone at the neck of the femur. It goes after spongy bone in the vertebrae. And so it attacks the trabeculae in here, and you can see on the bottom picture, that is spongy bone that's being attacked. And so the fractures that occur with osteoporosis are going to be hip fractures, like I said. Also, the vertebrae are going to collapse. They're going to have what we call a compression fracture, where they are too weak to support their own weight and they collapse on each other. So, who develops osteoporosis? Well, I haven't done it yet today, but I will. Your postmenopausal female. I'm going to throw grandma under the bus. Your postmenopausal female, after menopause, the ovaries shut down. The ovaries produce estrogen. Estrogen is responsible for stimulating osteoblast activity, bone building activity. Estrogen inhibits osteoclast activity. So when the ovaries shut down and don't produce estrogen anymore, the only estrogen that grandma has left is coming from her adrenal glands, and that's not very much. And those are the androgens that she's converting over to estrogen. And at some point, if the ovaries stop functioning completely, which they will, then even that's going to be gone. What happens is, so when your postmenopausal female stops producing estrogen, she's no longer going to have the ability to rebuild her bone as fast as she was before. Estrogen would stimulate the osteoblast. That's not going to happen now. And so your breakdown is going to be faster than your buildup. She's still going to be making osteoblasts and building bone, but she's going to be breaking it down faster. Now, who's at risk? Typically, an individual that didn't have a lot of calcium in their diet as a routine thing through their lifetime. Your postmenopausal female that maintained good dietary calcium intake and exercised regularly and didn't smoke is going to have a whole lot less issues with osteoporosis than someone who didn't exercise, didn't eat right, and smoked excessively. They're going to be more of a candidate for osteoporosis. Having said that, it can develop in anybody or no one. Osteoporosis doesn't play by the rules. You know, you could do it, your patient can be a 70-year-old female that did everything right, did exercises and exercised throughout their life so far, ate right, ate leafy greens full of calcium, did everything they're supposed to do, and they're still getting osteoporosis. Or you can get a 90-year-old female that didn't do a thing and smokes heavily and drinks heavily, and she's 90 years old and her bones are as sound as they were when she was 20. You're always going to have the outliers, and we can't explain it. But typically what happens is when you're a postmenopausal female, she shuts down her estrogen production, and that's what stimulates the osteoblast to grow rapidly to replace worn out bone. And so what will happen is that your candidate for osteoporosis will see her trabeculae dissolve like this. Same location in the neck of the femur, and here we have just a few trabeculae left. Also, your elderly female with osteoporosis will often see a loss in body stature as the vertebrae collapse. The upper vertebrae are going to break down. The lower vertebrae are going to break down because the spongy bone in the vertebrae is being dissolved, and so the upper vertebrae will sag down on that and become wedged. So she'll start leaning forward. So she will actually shrink somewhat, and then she'll become stooped as she stands too, because it also hurts. So, and you can see the wedging here. You can see how her shoulders are stooped. You can see the wedging of the upper vertebrae here collapsing on the lower vertebrae, and she's tilted over. Here's what the fracture looks like. There's your classic hip fracture right there, caused by osteoporosis. I can tell because these shadows here shouldn't be here. The bone is almost transparent. Now you have an outer layer of compact bone right there on the outside edge, but this should all be as white in here as it is down here. And look at the compact bone along the side here. It looks great, but this is all shadowy, meaning that the spongy bone has disappeared. It's been dissolved away. And then of course, same thing here. Here's a very bad example of it. This whole dark area here should be as white as the other side. This particular femur isn't as bad. There's a few weak areas here and here, but there's still a lot of spongy bone present. But over here, it's mostly gone. And this is where the fracture took place, right here. So who gets it? Mostly postmenopausal females. 30% of postmenopausal females over between 60 and 70, and 70% by age 80. So the longer your patient lives, the older your elderly female patient is, the more likely she is to develop osteoporosis. But the older she gets, it's less likely to have a greater impact. If she's been healthy for such a long time, if she hasn't gotten it by the time she's 80, even if it does develop, it's probably going to be minimal. Now, estrogen is key here, as if estrogen levels drop, then the risk of osteoporosis becomes greater, particularly if your female patient, like I said, exercise, diet, calcium, smoking, things like that. Now, do men get osteoporosis? Yes, they can. Not nearly as frequent. Testosterone protects most males from osteoporosis. Testosterone stimulates osteoblast activity. Males continue to produce testosterone from puberty till the day they die. And so that tends to interfere with osteoporosis. Males can develop it. It's infrequent in here. So, okay. Let's stop at osteopenia, and because it's 12:30 now. So we are, let's see, on Monday. If anybody, I think Monday's the day I set for the on-ground test. I think that's what I said. So if that's the case, I'm sure you'll correct me if I'm wrong, and that's fine. I'm trying to remember 4 different classes, what's going on. The lecture exam ends on Friday at midnight. The lab exam opens up on Friday and ends a week later. And if you're taking the lecture exam in class, did we say that was going to be Monday? If we did, that's what we'll do. If nobody wants to take it on ground, that's fine too. So, and I've probably got myself good and confused on that by now. So anyway, let me, if anybody has any questions, shoot me an email. I've got to get ready for my AP2 lab. So, and I'm sorry, but I'll be happy to answer anything. So, okay. Then I'm going to get us out of here, and I will see you all next week.